anything in there for anybody else. All right, so we're going to go ahead and get started here. Welcome, everybody. This is this is our third big Google Hangout that we've done all together. I've really enjoyed doing these. I have had usually quite a number of students who are expressing interest in this, especially as they're going through their board preparations, getting ready for everything. I really hope to make this as useful as possible. We're going to be talking about real content, things that are actually going to be, on practice exams, and the content that you need to know as physical therapists, primarily associated with pharmacology and gait. I do recognize that when I put in Facebook looking for suggestions for this particular session, I was kind of overwhelmed with the number of topics that were suggested to me. And so as a result, I had to pick just one or two in our brief time together, because I want to leave plenty of time for Q&A at the end, especially regarding the mechanics of the NPTE. As some of you have already noted on my YouTube channel, got a great YouTube channel. The two previous sessions we've done have been focused on, one, the basics of the NPTE and what you need to do to sit for the exam. And then the second one that we did was geared towards advanced strategies, is what I'd call it, where how do you need to be studying? What do you need to be doing to get ready for the NPTE? So truly, we're going to be talking about more again, specific topics here today. We're going to go through as much as we can in the time that's allotted. I'd like to keep this to less than an hour, just to make it more user-friendly, more people can see it. But yeah, we're going to dive right in. At the end, I'm going to attempt to have some Q&A, hopefully get lots of questions answered. So as we go along, if you do have a question, be sure to note it down. I do have it. The way this is going to work, I've got a PowerPoint presentation that we're going to go through. You won't be able to see me. You'll be able to hear the dulcet tones of my voice, but we will go through this PowerPoint. I think it'll be very instructive. I've got some good tips for you as you get ready for the exam, and we're going to go ahead and do that now. So here we go. Let's see if we can get this thing up and working. Okay. So pharmacology and gait, obviously there's going to be just way too much to cover in one session. Heck, there are books written about this stuff, pharmacology and gait. But we're going to hit the highlights about basically what you need to know going into the NPTE, and that's really my big goal here tonight. As just a little brief outline of what we're going to do. We're going to start out just a little bit about me and my program, and then we'll dive right into pharmacology, what you need to know, and then gait. The great part about gait is I've got some great resources to help you as you get ready for the NPTE, as far as resources for understanding the basics, and then how to approach all of the material that's associated with gait. Because obviously, there's so much written about gait. There's just been books and books and books written. I mean, whole chapters of different books and whole books written. I want to stress that tonight we're not going over everything. Rather, we're going over the basics and are going to help you get on the right path to passing the NPTE. All right, so a little bit about me. PT Final Exam, something I started, ptfinalexam.com. By the way, any of you who have not yet done it, I really highly encourage you to go to the PT Final Exam Facebook page. That most of you found out about this through Facebook, and the more word we can get out through Facebook, the more people benefit from free webinars like this, from the free stuff on the YouTube channel, on Udemy. I'll be talking about that a little bit later. But anyway, my whole goal I started in 2012, was to become an awesome resource for students preparing for the NPTE. Mostly because I just feel like there's not a lot of there's plenty. There's the Score Builders book, there's the Therapy Ed books, obviously there are those books and some review courses available. But I felt like it wasn't like really awesome stuff. It's kind of like, and I'm sure some of you will share this sentiment, it was like, okay, here's the book, good luck on the test. And that was about the extent of my NPTE preparation. Now, I did pass on the first attempt, and did pretty well. I took the exam 3 years ago, so things have changed slightly from 2011 till 2014. But I got a 720 on the exam, and nowadays the scale scoring has changed. It's more I guess, what would you call it? The FSBPT is very secretive about their scoring process. They don't want you to know exactly how it works, but we do know that it's more sensitive to scores right around the 75% mark. And so nowadays, it seems more and more common that I interact with students who have failed the exam by only 1 to 2 to 3 different points. Now, that makes the students really, pull their hair out, like, holy cow, how could I miss it by 1 question? Well, the truth is, you probably didn't miss it by just 1 question. It was probably a couple of questions, and then they just, they scale it so you don't know how many questions you got right, and they give you the scale score based on, again, there's several factors that go into it, one of which is the difficulty of the exam, because obviously different questions will be harder or have different statistical power related to different demographics of students. So in any case, it is dynamic, and it's hard to say what exactly it takes to pass, other than it takes 75% on the exam to pass. All right, so I started this whole thing back in 2012. I wanted to make the NPTE a little bit more manageable. I wanted to create a resource that was really good at helping people understand, helping the students like I was, who are a little bit lost about the whole process and where to begin. I wanted to help you get from the start to the finish in such a way that you feel very confident and competent. And that's one of the main things that differentiates me from, I guess, some of the other competitors in the field of test preparation, is that I truly recognize, and I'm sure the other ones do too, but I really recognize that you are my future colleagues. All of you who are listening here tonight, I've got 75 of you here so far. Everyone who's here is one of my future colleagues, and I want you to be not only competent in your practice, but I want you to be very confident, because again, this is something that I've noticed as I've been tutoring and taking students through the preparation process for a couple of years now, that as you increase your confidence, definitely this increases your test performance or your test scores. Now, I guess there are a couple of factors that go into that, but if you are confident in your abilities and you feel like you really know your stuff as a physical therapist, then that takes away some of that test anxiety that is really debilitating and almost paralyzing for so many students. I've got a couple of students right now in my class who, that's something that really, really bothers them, is that they feel so just paralyzed, scared, very anxious about this exam. And what I've seen, and this is not, this is not crazy, but the more you know, the more confident you feel, and the more confident you feel, the better you do on the test, regardless, in a way that's not necessarily correlated to your knowledge base. You're able to look at the questions with a keener eye. You're able to slow down, take a couple of deeper breaths. So definitely increase your knowledge to increase your confidence, and therefore increase your test scores. It's a great winning combination, and that's what I really focus on. For anyone who takes my program, PT Final Exam is focusing on this specifically, improving competence and confidence, and not just test tips or tricks or what to wear on the day of the exam, or what yoga pants to wear. I don't know. I want, real good qualified people becoming my colleagues, and therefore I train you to do that. All right, so we're going to dive right into pharmacology. Now, obviously, as physical therapists, you're telling yourself right now that we don't prescribe medicine. That is absolutely the case. We do not prescribe medicine. We are simply let's see, what do they call us? The allied healthcare professions. Basically, we take care of people after they've been given the medicine, and usually we are the boots on the ground when it comes to seeing how well these medicines are working. I mean, honestly, you think about physician visits these days. My brother's a physician. Physician visits these days are, maximum 8 minutes. So tell me how much you're going to know about a person's, how they're really being affected by medicine in 8 minutes of an average visit. It just isn't happening. And so therefore, this increases the necessity for us as physical therapists to recognize and understand what is going on with their pharmacology, so that we can communicate effectively with our peers, our colleagues, both in the nursing field and in the physician medical field. absolutely critical that we understand at least the basics about pharmacology, especially as they relate to the most common pharmacological agents or most common medicines. All right, so what do you need to know going into this exam? I admit when I was getting ready for the exam, my first thought was, holy cow, how in the world am I ever going to memorize or know all of these medicines? I mean, for instance, my brother in medical school, I can't remember exactly how many classes, but he took numerous classes, not only on how the medicines worked, but on microbiology and how the whole body worked relating to organic chemistry, microbiology, all of that. So obviously there's just so much to understand. Our job is to understand this, the most common medications for the most common conditions and how it relates to physical therapy. So think about that. When you consider that that is the case, all of a sudden it becomes maybe a little bit less scary, meaning that, okay, all I need to know is, most of the time people come in with these types of medicines for these types of conditions. So I just need to understand how that affects me as a physical therapist. Plus, how can I communicate to the physician or nurse whether the medicine is working well, not working well, or if there needs to be some sort of big change that I can see as a physical therapist. Not that we're recommending things, rather we are just being the boots on the ground and the eyes in the field that help the physicians understand what's going on. I can't tell you, I work with my brother, physician, and I can't tell you how many times he and I have a conversation on the phone or in person about, I've really noticed that, for instance, pain. I've noticed this person, they are really hurting when I get them up out of bed, in the inpatient setting. I really have a hard time getting them up because they hurt so much. So he then makes adjustments to the pain medication, also taking into account the input from the nursing, input from the patient, input from physical therapy. We really work together as a team here. So again, most common meds for the most common conditions. So we're going to talk specifically about a couple of these. Now, the one that I think we run into maybe not the most, but maybe the one that we run into the most problems are the opioid type medicines. So these are the morphine-like substances that are derived from the opium poppy, and their whole job is to they do a couple of things. Primarily, they are for pain relief. So almost all of us, whether in clinicals or whether in real life, we get to see patients, tons of patients who come post-op. Usually their first couple of visits, almost categorically, their first couple of visits, they have narcotic-based or opioid-type pain medication on board in order to provide them medium to maximum pain relief. These are usually, most of the time, this is post-op. And the reason that that is the case is because these substances can create addictions. Therefore, for the most part, opioids are not used long-term. If they are used long-term, they like to transition them to a patch or some type of extended release formula so that you don't get as much of that high or the buzz, or well, not the buzz, what is it? Just the euphoric high that comes with these opioid type medicines. Again, they are very prone to addiction, and in combination with addiction, they also develop a tolerance. So the definition of tolerance is that more and more medicine is required to achieve the same effect or the desired effect. Therefore, this addiction just becomes a negative cycle that they love, that they purposely and willfully seek out narcotics in order to get that euphoric high, and then in addition to that, they become more and more tolerant of the medicine, meaning that it requires more and more to achieve the same effect. Therefore, it's, again, terrible cycle of addiction. Now, dependence is something that is a little bit different. Consider this: all these three terms are different: addiction, tolerance, and dependence. Dependence means that you become physiologically dependent on the substance, such that if they removed the substance, you would start to have adverse effects from its removal. So the good news is that for opioids, most of the time, this dependence will not kill you, or the removal of the medicine or the removal of opioid type medicines, it won't kill you. You're going to have some side effects. You're not going to feel great, but it typically won't kill you. Now, the big thing that I want you to consider, though, is as physical therapists, we need to consider what this medicine is doing for our patients. So number one, it is providing pain relief. And speaking anecdotally, I tell my patients, especially post-op ones or ones especially with like shoulder repairs, rotator cuff repairs, any sort of post-op shoulder or post-op knee, I tell them almost categorically, be sure to take your pain meds about 30 minutes prior to coming into the clinic. Now, the 30 minutes is so that that narcotic can reach its peak effectiveness, so that then with the pain relief, I can continue with my treatment without being inhibited by pain. Another good example is if you're working inpatient with someone, you have to get them out of bed after, let's say you're in the orthopedic ward, they've had their total knee replacement, and you need to get them up out of bed for the first time. You're going to want them to have good pain meds on board so that they're able to tolerate more and be more functional. Now, the disadvantage here, and this is also key to understand, is that these opioids also cause drowsiness, slowness, and kind of this general dullness of mental status. Therefore, for the most part, our instructions when we're talking about the HEP, home exercise program, or if we're trying to, just give them simple gait training instructions, sometimes those pain meds are going to make them duller, and they will not be able to understand your instructions as well, simply because their brain is not working. Plus, good thing to remember is that you are not supposed to drive while on opioid medicine because of that drowsiness and sleepiness and slowness, that it's like driving drunk. And so again, a good thing to educate your patients on, although typically you'll be educating the caregiver in this case because they are having simply because they can't remember anything. When they're on the opioids, often they just don't remember anything. So there you go, kind of a crash course on the opioids. I've listed a couple there. I think the ones that I run into most in the clinic are the oxycodone or the hydrocodone. Those are definitely the most common ones. If you're working inpatient or someone with really severe intractable pain, then you're going to start getting into the fentanyl. That's something like used in emergency rooms and is super heavy duty pain relief, but incredibly high addiction risk. Therefore, and same with morphine, it works really well to decrease pain, but it also creates this risk for addiction, tolerance, dependence, all of that. So there you go. That's where I see opioids most. Usually post-op or pretty severe pain. Just as a side note, you can get these in patches. So this extended release patch, and that's something that they stick on the patient's arm or on their buttock and is slowly released over, it depends on the patch, but 24 to 72 hours worth of pain relief without that initial like bolus of you took a pill and now you're having the euphoria or the opioid stupor as it comes. Right, so some of the other medications that we run into, maybe perhaps more commonly, we've got the NSAIDs, or non-steroidal anti-inflammatories. Now, key distinction here, if you check in your pharmacology books, the most common one is called Pharmacology in Rehabilitation. Now, this is the most common book across PT programs in the United States. So if you don't have this one, this is by Ciccone. Pharmacology in Rehabilitation. This is one where it has a good explanation of all of these, plus it goes into extreme depth on the mechanism of action and the different type of adverse effects and the agonists, antagonists, all of that. So obviously we don't have time to go over everything there. I do recommend that you head to Pharmacology and Rehabilitation for more information, written by Ciccone. All right, so just so you know, acetaminophen is not technically a non-steroidal anti-inflammatory. Rather, acetaminophen is just an aspirin-like analgesic, simply because it is not a COX-1 or COX-2 inhibitor. COX-1 and COX-2 inhibitors, if you, again, go back and look at the books, look at your notes from class on this one, but cyclooxygenase is one of the main enzymes that helps create prostaglandins. So if you look at what prostaglandins do, now there are, if you, again, doing a little research on this, you'll discover that there are good prostaglandins and there are not so good prostaglandins. Usually COX-2 is associated with the not so good prostaglandins. Therefore, if you can get a good COX-2 inhibitor like Celebrex, you're going to be in good shape at inhibiting the bad prostaglandins, so to speak, the pain and inflammation prostaglandins that are always associated with tissue injury. What happens is whenever there's an injury, markers come out from the cell, and the cell actually produces these prostaglandin type markers that then do two things. They cause the blood vessels in the area to become very leaky, and therefore you get the swelling, the fluid coming into the area, flooding the area. Plus, on the pain side of life, they make the pain receptors, the nociceptors, much more sensitive, therefore creating both the pain and the inflammatory response after an injury. Now, the good news is that if you can inhibit those prostaglandins, you're also going to have good pain relief and anti-inflammatory effect. And that's what they're primarily used for, is the pain and inflammation. But the good news is that they are typically not, I guess I've never heard of a case. I mean, anything's possible, but they don't typically create addictions or have any sort of dependence or tolerance issues. Rather, they're just a good mild to moderate pain relief. And so long term, when we've got a patient who has chronic pain or whatever, usually we're going to be talking more along the NSAIDs or acetaminophen, Tylenol type medicine. Something important to remember is that aspirin is technically a non-steroidal anti-inflammatory. It has the same COX-1, COX-2 inhibitor action. Therefore, do not underestimate the power of aspirin, both in its anti-inflammatory and pain relief, but also in its anticoagulation, or helps keep the blood a little bit thinner so you don't get blood clots. All right, so mild to moderate. Now, the reason, this is really interesting. I'd never really considered this, but most people know that you're supposed to take NSAIDs with some sort of food simply because of the main side effect or the adverse effect of NSAIDs is gastrointestinal issues. Now, the reason that is because, like I said, there are good prostaglandins and there are bad prostaglandins. The protective prostaglandins that exist in the gut are used in a typical normal healthy person. What they're doing, the protective prostaglandins, because the acid would try to eat its way through the gut. With protective prostaglandins, those create or they inhibit acid production and then promote mucus production. Part of that, again, they're geared towards that inflammatory type response. They're making more mucus by making it a little more leaky. Therefore, if you inhibit both the good and the bad prostaglandins, that's what causes the gastrointestinal distress or the stomach, usually stomach pain and problem that comes with using typically ibuprofen. Now, the good news is, and naproxen, but the good news is that with something like Celebrex, now Celebrex is still being tested. There's still some debate in the literature exactly about the mechanism and if it's perfectly as good as it purports. But because Celebrex is a selective COX-2 inhibitor, you typically don't have the GI issues that you have with other NSAIDs. So that's kind of fun. COX-2 inhibitors, cyclooxygenase. Celebrex is maybe the best one at preventing the gastrointestinal issues, but for sure, aspirin, ibuprofen, naproxen are your go-to NSAIDs. And then acetaminophen, usually acetaminophen is included with the opioid type medicine. So when you're talking about hydrocodone or oxycodone in either Lortab or Percocet, those are, again, some of the most, and Norco, talking about Norco, some of those three most important opioids, those typically come with acetaminophen in them. So again, usually it's like 325 milligrams of acetaminophen combined in the tablet with the opioid. Again, just so you can get more pain relief that lasts a little bit longer and works on a different pathway, because the cyclooxygenase, that's occurring at the cellular level of the injury, versus the opioids, that's working on a more central level, central nervous system type, trying to dull the pain centers in the brain, versus the acetaminophen, which is trying to dull the pain and prostaglandin issues that are down, well, not the acetaminophen, but it's trying to create pain relief in the area of the injury. So there you go. All right, so now when you get into cardiac medications, this is where things get really hairy, simply because there's so many. I've listed 4 here. but I want to stress that there are a number of others. I mean, for instance, if you just consider like antithrombotic agents, we've got the nitrates like nitroglycerin, yeah, diuretics, obviously, and alpha adrenergic antagonist agents. I mean, there's so many. I wanted to focus on what are the basic ones and the ones that happen maybe the most often. All right, so beta blockers, they block the beta adrenergic receptors in the heart, which those beta adrenergic receptors take sympathetic stimulation. And so if you can block the beta receptors, you're going to block that sympathetic stimulation. And therefore, the biggest thing is you're going to have a reduced heart rate. Reduced heart rate. So the good news about reduced heart rate is that usually when you're talking with someone who's got heart issues or other type of cardiac distress, kind of the typical response is that when the heart has ischemia, your body recognizes, holy cow, we're not getting enough blood to the heart. So what do we need to do? We need to pump more blood. So when you pump more blood, what does that do? It makes the heart starve for oxygen even more, and it creates this cycle that eventually leads to myocardial infarction. So if you can decrease the heart rate artificially, you're going to decrease the stress, that cardiac stress, and therefore you'll be able to relieve some of the angina type symptoms. You'll be able to relieve the stress on the heart, especially associated with ischemia. Now, why is this important? And I guess why are all of these important? I want you to consider that. What would decreased heart rate cause you to think about when you've got your patient in the clinic? Just like it says, you're going to have a blunted heart rate response, meaning that if you stick them on the treadmill and you measure their heart and you're like, oh, they've only increased their heart rate by 5 beats per minute. Therefore, I need to increase the exercise. When truly what's happening is that you have a blunted heart rate response, whereas without the beta blockers, you would have probably had a 20-point increase in heart rate. And therefore, again, this comes back to cardiac rehab that we're not going to talk about tonight, but usually you take heart rate, at the same time you take rating of perceived exertion. And when you combine those two, that gives you some information to make the decision. For your decision to continue, to increase workload, decrease workload, or send the patient home or send them to their physician. Basically, you're taking heart rate in conjunction with rating of perceived exertion, because if they've got beta blockers, you can't just trust their heart rate to tell you how hard they're working. Like in normal individuals, I don't know, anyone who's what you'd consider physiologically normal, you have a standard heart rate response, increase in heart rate to activity. And when you've got beta blockers on board, you're going to have to make your decision based not only on the heart rate, you're going to see it increase some, but you're going to have that rating of perceived exertion be a key point for you. All right, ACE inhibitors, or angiotensin converting enzyme inhibitors. Oh, and I wanted to point out the suffixes at the end of these words: atenolol, metoprolol, propanolol. That's probably going to be your best friend, is that most medications in most classes share the same suffix or prefix or some sort of the same word base. Therefore, you're able to recognize medicine that's in that class by the suffix. So spend a lot of time on those suffixes. ACE inhibitors, angiotensin converting enzyme. What this does, angiotensin is a hormone that increases blood pressure. And so if you can inhibit the converting enzyme, then basically what you do is you get reduced blood pressure. And the caterpillar, enalapril, lisinopril, lamipril, you can see a pattern showing up with those prils at the end, the ACE inhibitors. This decreases that load on the heart simply because if you don't have to push as hard to get the blood out, you're going to have better aerobic perfusion as you're walking or exercising or otherwise living your life. If you don't have as much blood pressure pushing back on you, your heart is going to have better cardiac output. That preload on the heart is, the load on the heart is simply going to be less. And so again, this affects your exercise, because if you're looking at their response to exercise and you're checking their blood pressure, you're going to notice that there's a blunted blood pressure response. Or let's say, just for fun, and this happens not infrequently, let's say you had too much of an ACE inhibitor. What would you see show up? If you had too much ACE inhibitor, you're going to have orthostatic hypotension. Orthostatic hypotension, meaning that their blood pressure is going to be way too low. You're going to have them stand up, they're not going to have enough blood to their brain, they're going to pass out and hit the floor. So definitely one to watch out for, those ACE inhibitors, because if you have too much, you can cause orthostatic hypotension. Calcium channel blockers, briefly, they in essence block the calcium that enters into the cardiac tissue. Therefore, what they're doing is they're decreasing the contractility of the heart muscle, decreasing the strength of contractions. Therefore, and I guess part of that too, so you're probably asking yourself, well, why do we want to decrease the strength of contractions, especially when you look down at digitalis or digoxin? But the point is that when you block the calcium channel, not only are you inhibiting the cardiac musculature, but you're also inhibiting the smooth muscle that surrounds the blood vessels, the arteries. Therefore, you have a vasodilation effect that is in the cardiac vessels, thus allowing more blood to perfuse the heart, and therefore giving you obviously giving you better and more efficient heart rates and cardiac output, because the heart's not nearly as stressed, because you're getting better blood supply to the heart and not having ischemia. That's key. So you have that decreased vascular resistance that comes as a result of vasodilation. And typically you also get a decrease in heart rate here. So if you have all of these things going on at once, you've got beta blockers, calcium channel blockers, and ACE inhibitors, you're going to artificially be decreasing heart rate and decreasing blood pressure. Now, when you decrease both of those, again, big key to watch out for is orthostatic hypotension. Static hypotension. And if you don't know what that means yet, then that's a good assignment for Wikipedia. Orthostatic hypotension. All right, and then finally, digitalis, or digoxin is what I want to talk about. This one is primarily used in congestive heart failure. When you've got congestive heart failure, again, this is a good Wikipedia assignment for you. Congestive heart failure simply means that the heart has hypertrophied to the point that it is no longer an efficient pump. And so with digitalis, there's a little bit of debate about the exact mechanism of action. However, we do know that it increases the contractility of cardiac tissue, meaning that and it also decreases the heart rate. So you have fewer but better contractions of the heart. Fewer but better. And that's important. Now, and again, I think there's a good practice question on this in the Score Builders book about what would happen to the PR interval with digitalis. Again, if you have fewer beats, that means that you're going to be lengthening out or elongating your EKG tracing. And so in essence, this P to QRS distance is going to be increasing because you're making the heart rate slower and getting fewer, better contractions, therefore increasing that PR interval. PR interval. I get a lot of people talk to me about that one when it comes to the Score Builders practice exam. All right. Oh, and the next one I want to talk about briefly is baclofen. So baclofen is one that we use in hypertonic type issues. So a lot of times we're seeing this in cerebral palsy type patients, spinal cord injuries, upper motor neuron issues. Baclofen is just simply meant to decrease tone and spasticity. I'm not going to go into the actual mechanism of action, simply because the important part is understanding that we are reducing spasticity. So why is that important? I want you to consider that for a moment. I'm going to let you ponder on that briefly. Why is it important to reduce spasticity? When it comes to physical therapists, we've got to have a reason for everything or we have to understand the reason, because in this case especially, baclofen is something that the patient can develop a tolerance to baclofen. Therefore, that's why you and I as physical therapists, we are the boots on the ground, and we tell the physician when we feel like, okay, they need a little bit more baclofen or they don't need as much baclofen, because the more baclofen you have, the more like a wet noodle they become, the limper they become, or the less baclofen they have, the more tone shows up. Again, baclofen is meant to reduce tone. More baclofen, less tone. All right, so if you have reduced tone and spasticity, we want to translate that into function. Now, I had a good friend in college who had cerebral palsy. She was born with cerebral palsy and was not affected with mental status. However, it did affect her lower extremities significantly, and she walked with a scissor gait and had, let's see, how would you put it? She had knee flexion contractures that she could not straighten out because her hamstrings were always in terrible spasticity, gluteals, and the adductors of the hip. Those were all in spasticity, and they were prohibiting her from walking very well. She tired very quickly when she walked. But that's the great part about baclofen, whether, in her case, I believe she had oral baclofen. When she took oral baclofen, what that did is it increased her function by allowing her legs to straighten out a little bit more. Not perfect, but it definitely reduced the tone so that she could walk a little bit more normally. And the other thing is if you're considering cerebral palsy kids especially, we're looking at basic hygiene and family care. Any of you who've had children, like right now I've got a 10-month-old baby boy. I've got 3 kids, but 10-month-old baby boy right now. He is the most persistent at fighting us every time we try to change his diaper, put on clothes, whatever. He fights us, fights because I don't know, he's just kind of in his nature. He pushes back. And so if you consider someone with severe spasticity, or they cannot extend their elbows, they can't bring their legs, we're talking diapering, if they can't bring their legs apart because the adductors are so spastic, you're going to have just a heck of a time getting good care and hygiene to that patient. So therefore, cerebral palsy folks especially really benefit from baclofen. Now, baclofen is most often in these cerebral palsy kids given intrathecally, where they put the pump just under the skin in the abdomen, and then they pump it, obviously an electronic pump, they pump it into the subarachnoid space in the spinal cord. Therefore, because there are some side effects to baclofen. One, obviously if you decrease the tone too much, you're just in trouble. But if you have intrathecal baclofen pump, with that you can have the dose be much smaller because you're delivering the baclofen directly to the area that you're after. Plus, you can control it more precisely. So a smaller dosage in the exact right spot goes a lot farther. So you don't have the tolerance, the tolerance issue that you usually have with baclofen, that you, in essence, become more tolerant to baclofen and requires increases and decreases in dosage based on the patient's tolerance of the medicine. So again, baclofen, that's one that comes up, especially if you're working in a pediatric setting. Baclofen, especially that intrathecal baclofen pump, that you want to be aware of when you're doing treatment, so that you don't, I can't imagine why but if you had them on their belly on something, on the edge of a table, I don't know why you would ever do that, but you don't want to damage or otherwise cause problems to the baclofen pump. All right, we're just cruising right along. Holy cow, we've already been going 45 minutes. Gait is I'm going to have to refer you to some resources on this one. Gait issues I created, and I hope all of you have taken advantage of this so far. On Udemy, go to udemy.com. I think it's udemy.com. Anyway, you can find a link to it on my blog, ptfinalexam.com/blog. Udemy, I created a free course that has about an hour's worth of description with drawings of PT gait analysis and deviations. And this is not geared towards prosthetics, but is geared towards normal gait and what normal deviations occur. So if you haven't done that already, please, please, please head over to Udemy. I've got 550 students who've already done that so far. Go through all the videos, lectures, and let me know what you think. For most people, they've been really extremely beneficial, and I hope they are for you. The title of the course is PT Gait Analysis and Deviations. And as I said, you can find that on my blog, ptfinalexam.com/blog, or you can head over to Udemy and type in PT Gait Analysis and Deviations. I think I'm the only course about gait anyway, so if you put in gait, you're going to be in good shape. It's totally free. I think you can sign in with your Facebook account, and you're just good to go. Take that as much as you want. And when it comes to prosthetics, I also wrote a good paper on prosthetics, on how, just kind of a quick and easy guide to understanding prosthetics. Check that out at ptfinalexam.com/prosthetics. Or you can always, as always, go to ptfinalexam.com/blog for all of this information too. All right, let's see. Various abnormal gait deviations. I explained this in detail in that Udemy course, so I'm going to send you over to the Udemy course to really understand most of these, and I describe them in relative detail. Just in conclusion, in conclusion of this part, we're going to take questions and answers right after I finish up with these slides. I only have 2 or 3 more slides. But just in conclusion, as you're headed into the NPTE, make sure that you're making something about like this. This is a table that was made by one of my students, and is just a star shining example of what you need to do to understand not only the drugs, so if we're talking about ACE inhibitors and a couple of examples of ACE inhibitors, their action, indication, side effects, and then the PT considerations. That's what really counts. That when you are in practice, you're going to be looking for how does this medicine affect my life? Or, talking about Coumadin and Lovenox, nitrates, diuretics. Basically go through the whole list. I take that. Let me back up a step. When you're going through your studies, I recommend you take a diagnosis from start to finish so let's say we're talking about subacromial impingement. Define what subacromial impingement is. Then what you're going to do is make sure you understand how to examine it, how to evaluate and differential diagnosis of the subacromial impingement from rotator cuff tears, slap tears, AC joint issues. You're going to separate all those out and look for the distinction. And then you're going to be talking about, obviously, when you get to the cardiac and pulmonary conditions, you need to talk about what the medical treatment is for them. So what sort of medicines are they on? What sort of surgeries are they going to have typically? And then always bring it back to interventions and what does it mean for a physical therapist? Key. And the same thing could be said about common gait deviations. I know like the Score Builders book has got a great couple of tables on these common gait deviations. I know that McGee, the orthopedic physical assessment, has some of the best tables I've seen on just in-depth what is wrong at each phase of gait. And definitely, I used McGee as the primary resource for that Udemy course with my drawings too. So be sure to head over to Udemy. All right, so there you go. I'm a big fan of active type learning. If you're just reading the book, I don't think that's good enough for you. I think you have to be actively tables, bulleted lists, and really put things together. All right, as always, every time I do one of these things, I always try to throw in a couple of discounts to make it worth your while for coming. I know some of you who are taking the test in this month, at the end of this month, in a couple of weeks, you might benefit if you're looking for more information, more material, especially videos. You can check out the home study bundle on the ptfinalexam.com. If you use this code, it will reduce the price by $50. Plus, if you send me your receipt, I will add another 12 hours worth of video. That's just from the class I just barely polished up. You'll have so much video, you won't even know what to do with all this video. A lot of it's me explaining concepts similar to what you saw here today. Plus, you'll get to see a lot of principles in action. And the key point, though, that home study bundle, I try to coach you and take you through what you need to know to study for the exam. Now, obviously, there's just no way that I can compress 3 years worth of knowledge, classes, and other information into it'll be about 20 hours worth of videos. No way that I could totally compress all that, but I try to hit the highlights. And again, I'll send you an extra bonus of those 12 extra hours plus an extra $50 off. You're going to enjoy that. Let's see. Yeah, Facebook promo is the code you'll want to use for that. And then PT Final Exam, or PTFE, is going to reduce. I've got a study guide out. That my study guide is mostly geared towards tables, lists, and other ways of putting things all together. You can get $20 off by using I guess I didn't put that there, $20 off the PT Final Exam study guide, which also includes 200 practice questions. If you haven't taken those yet, that's a good resource for you. Since most of you have probably already taken every practice test known to man, this is a test that I authored, 200 questions that are included with that PT Final Exam complete study guide, which you can find on my website under the resources tab. You'll find all of this stuff. All right, so thank you so much for coming here. We're going to switch out here very quickly to the Q&A session where you can ask your questions. I'm going to open up those boxes. You can start typing in your questions. As always, feel free to email me, admin@ptfinalexam.com. And always be sure to check out ptfinalexam.com, especially the blog. I try to update that very frequently. Plus, please like PT Final Exam on Facebook. Most of you found out about this via Facebook. As I said earlier, you could really do, pay it forward by liking me on Facebook so that we can get the word out for the next one. I usually have one of these before every exam, or kind of whenever I feel like it. And these are recorded on YouTube for you later. But yeah, be sure to swing by and like PT Final Exam on Facebook, if nothing else. That'll really do me a big favor. I appreciate that. All right, so now we're going to dive into the questions. I'm going to open up, I'm going to turn off the PowerPoint, and we're going to yeah, head back over here. You get to see my bright and smiling face. All right, let's open up the Q&A. All right, let's see if we can get anyone. Okay, let's see. Oh, we've got lots of Q&A. Let's see. Chris Davis, Gait course was awesome. I really appreciate your feedback on that. That's something that again, you know, it's just the PowerPoint slides and my drawings, but it's how I understand it, and hopefully it will help you understand it. So I really appreciate your feedback on that. All right, let's see what else. How much should we score on a PEAT or practice exam? Obviously, you have to get 75% to pass the real exam. So you definitely need to be up in the 70s, if not the mid 70s, definitely above 70 consistently on practice exams. And that's going to be absolutely key that you're getting that far. All right, let's see. Let's if we see signs of drug toxicity, what should our course be? Well, obviously, that's something that needs to be referred on or explained very clearly, or at least it depends on how terrible it is. So let's say you've got, I don't know, let's say the baclofen is causing them to have labored breathing and they can't breathe, they're turning blue on you. That means that drug toxicity requires a call to 911. Most of the time, though, like the one that I see most frequently is someone comes into the clinic with a slightly decreased blood pressure, and that happens usually over the course of 2 or 3 visits. I've got their blood pressure and I notice that it's too low. That's going to tell me that they've have too much of usually the ACE inhibitor type med on board. It could be other ones too, but in any case, that's where you will refer. Well, it's not an emergency, so you're not going to call 911, but you're definitely going to send some documentation and a phone call over to the physician's office. Let's see. Could you please explain how to remember the EKG changes or ECG? I wonder, you know, I've always wondered why people say EKG. Like in all my classes, we said EKG, but ECG, cardiography. Could you please explain how to remember the EKG changes related to the drugs? Simple. If it reduces the heart rate, it makes it slower. If it increases the heart rate, which I don't know what, you know, I guess there'd be some drugs that would do that, puts it all closer together. You know, that's one that is hard to answer right here. And I'm not sure if there's a really awesome resource that puts that all together. Basically, if you understand what the drug is doing, usually you can correlate that to either tachycardia, bradycardia, or if the specific drug is meant to decrease atrial fibrillation, then the result of the drug would be to decrease atrial fibrillation, that sort of a thing. So again, sorry, not a real specific answer on that one, but definitely one way to look at it. Let's see. While doing questions on orthosis, I came across a question where PT has to choose between a parapodium and a standing frame. Is there a criteria to choose between the two? Not that I know of. Can't say that I'm the expert in the world on parapodiums and standing frames. However, yeah, that's a good question. O'Sullivan's Physical Rehabilitation is going to be the best source on that one for sure. So, yeah, sorry, no great answer for that one. Let's see, which drug causes bradycardia? That is a good question. Off the top of my head, again, you're asking me to list it just off the top of my head. What causes bradycardia? So opioids for sure, because it causes this depressed mood, and that can definitely cause the bradycardia. That's the one that comes to my mind most quickly. I'm sure there are others. Well, the beta blockers, obviously. Why am I thinking? Which drugs cause bradycardia? Yeah. So the beta blockers are obviously going to cause decreased heart rate, which eventually leads to, if you have too much of them, you're going to have bradycardia. And the same thing for calcium channel inhibitors. If you're decreasing the heart rate. Sorry, totally spaced on that one, but yeah. Let's see, what are you recommending for a score on my 200 practice exam? 200 question practice exam. Okay, so I've been trying to gather data as best as I can for that exam. Now, the truth of the matter is that at the end of the day, you have to have 75% on the NPTE, but for the most part, I'm getting reports from students that my test is slightly harder than the NPTE, more along lines of like the therapy ed tests. So you definitely need to be at the 70 range. 70, 72 would be, I'd be more comfortable about. But like with the score builders test, you probably need to be up in the 76, 79, 80% range on those score builders tests. Because typically the score builders tests are a little bit easier than the real thing, and the therapy ed tests are a little bit harder than the real thing. I think mine's right along lines with that. Let's see. How do we consider the change in heart rate and cardiac output related to medicine while we are doing the therapy practice? I think what you're trying to ask is, how do we measure it as we're treating a patient who has all these meds on board? What are we doing? So if you're doing cardiac rehab, you're taking their blood pressure and heart rate at least every couple of minutes, if not a couple of times, at least once or twice during each activity. Therefore, yeah, looking at a good pulse oximeter and a sphygmomanometer or blood pressure cuff to double check what their heart and lungs, not lungs, but blood pressure is doing. And then you also correlate that with their rating of perceived exertion, and that will give you a good picture of how hard are they working and what their heart is doing. Let's see. Dayu, good to hear from you. It's we have 2 weeks left at this point until the test. Any recommendations how to use this time efficiently and effectively? All right, so I've tried to understand why some people feel compelled to take as many practice tests as possible. So, for instance, I've had a couple people email me recently about how they're planning on, between now and the exam, taking at least 4 or 5 practice tests. Now, that's not a bad thing, but I think a better thing to do would be to take maybe 2 practice exams and spend tons of time just totally dissecting out the questions, making sure you understand totally and completely what the questions are asking, why you missed them, and then compile a list of your weaknesses such that, like, if medications are your weakness, or if, I don't know, interventions for rotator cuff repairs, if you find that those are your weaknesses, then I would spend your time looking over your weaknesses rather than just running and taking another practice test just to see how you did without any studying in between. That's what puzzles me. Why don't run to a test just to see how you're going to do without studying to make sure you're doing better on the tests and on the next test and on the next test. So there you go. Next 2 weeks, find your weaknesses and fix them. Let's see. If a patient is referred for cardiac rehab after an episode of myocardial infarction or any cardiac condition, if the patient feels uneasy or anxious during the rehab, what are some scenarios when the patient needs to report it to the physician? That's a good question. If it's just anxiety or unease, most of the time the physician is, to put it callously, they're not going to care as much unless it's like really debilitating or otherwise causing them to like skip their therapy sessions. That would be something to definitely watch out for. But most of the time, you're just going to educate them about what the condition is that they have and how you are going to help them by improving aerobic capacity and helping them get back to normal life. So I hope that answered your question. Let's see. When a patient is on anticoagulation therapy, which is the most important to monitor? Usually the INR. You're talking about the prothrombin time, talk about a tongue twister. Most of the time, the, what do they call it? I was trying to think. At the University of Utah, they had what was it? It was a whole team dedicated to preventing blood clots. And their job was to make sure that the INR was in its target range, 2 to 2.5, and that the patient was well educated as to what they needed to do to keep it in the target range, what diet they needed to maintain, all of that. All right, let's see. Can I talk about manual muscle test grades? So probably not going to talk about that tonight. Definitely check out in, heck, if you've got a good review book, check out Score Builders. Like I've got both Therapy Ed and Score Builders. Both of them have awesome tables about manual muscle tests. And then that is memorization, manual muscle tests. Let's see. So the difference between ST segment elevation and depression and what that means for PT in a medical aspect. So when you have someone who comes in with a ST elevation greater than, I can't remember, 1 to 2 millimeters on a strip, basically what's happening is that ST segment is elevated, meaning that the heart is not depolarizing as it should. There's something blocking the way. You have ischemia. With ST segment elevation, that means an acute heart attack is either occurring or is about to occur. And in that case, you stop everything and either walk them to the emergency room if you're working in a hospital setting, or tell them to get over there ASAP. Now, ST segment depression can also mean ischemia to the heart. However, typically ST segment depression occurs after an incident or after ischemic tissue damage. Therefore, when you're treating someone with status post myocardial infarction, congestive heart failure, any sort of thing where there's been ischemia to the heart, typically you'll see a permanent change to the EKG with ST segment depression. So what that really means is that if you see ST segment depression, it's not going to change the way you treat them necessarily. You'll be treating them for that cardiac episode that they had. So if you see the ST segment depression, it doesn't mean stop everything and send them back, because that's why the physician sent them to you in the first place, is because they have ST segment depression. It's that ST segment elevation, or the STEMI, ST elevated myocardial infarction, or the STEMI. That's when you really need to stop everything and send it on its way. All right, let's see. Dayu, I hope I'm saying your name right. Dayu, thank you so much for your kudos on all that. 2 millimeters, good. Good. Everyone's putting down 2 millimeters, depression or elevation. What is the best reference to read about terminating exercise absolutely during cardiac rehab? Why can't I remember the name of the book? Cardiopulmonary Rehabilitation by who? Basically, you just need to understand when the body is in trouble. And so we're talking, obviously, with any sort of ischemic tissue damage, severe drop in cardiac output or blood pressure. Those are the ones that are like the absolute termination points, or turning blue, cyanosis, or if the patient asks to stop, you stop. As I said before, one of my favorite jokes is, what's the difference between a therapist and a terrorist is that you can negotiate with terrorists but not therapists. But in this case, you can. Let's see. Oh, you ask a brilliant question, Kyle. Do we have to know anything about the OASIS form? Not for this test. If you work in a home health setting, yeah, you'll have to know something about the OASIS form. Yeah, I look at it frequently, but I definitely have never filled out an OASIS form, and I hope I never have to, because those things are honestly like 45 pages long, filling out stuff. Let's see. For Parkinson's patients, do we have to tell the patient to not take meds before exercise time? Depends on the patient, depends on the level of Parkinson's, the amount of Parkinson's, and the amount of meds. Sorry, no straight answer to that question. Let's see. Oh, here we go. Aman, you can remember it this way. Ischemia is depression and infarction is elevation. Good. So all of that. Okay, let's see if we've got any more questions. Digitalis, is your course? Here we go. Is my course entirely online? Yes, totally online. I have each Saturday, well, the way it's been working, the way that works best for most people, is on Saturday mornings we have a live session together where we go over cases and practice questions, and then I give you assignments for the week. The initial reaction to the assignment when you look at it is like, holy cow, how am I ever going to accomplish this in a week? But it pushes you through all of the material, and then we come back and discuss the material. There's no way we can discuss 3 years worth of it in just the amount of time that is given to us in the 6 weeks of our course. It would take 3 years to go over it, obviously, but it's totally online. We do live sessions on Saturday. We do Q&A sessions on Wednesday evening. And then all of those are recorded so that you can then watch them if you happen to miss it, or if your internet dies or whatever, you can watch those later. So yeah, definitely check out the course. I call it the Mastermind Study Group series. And that's one where I be sure to sign up early. The next one's starting November 29th and is a really great resource. Most people, I mean, you can read, I've got some unedited star reviews, much like Amazon, just to show you what people are saying and what people think about it. So be sure to check that out, Mastermind Study Groups. Let's see, would there be a webinar on evidence-based practice? That's a good question. Evidence-based practice. Hard to have a webinar just on that because, honestly, everything we do should be evidence-based, meaning that we got it from either a good resource textbook that got it from evidence or randomized control trials or all that. So I don't think there's going to be a webinar just on evidence-based practice. Maybe we'll talk about it briefly. Let's see. Perna, can I get the recent videos or the extra questions? Well, you already have the questions as the bundle, and it's just videos. Absolutely. Send me an email. I'll send you the link. No problemo. So here's a good question. These kind of questions do make me smile a little bit, simply because, can you explain EKG? There are books and books and books and books written about EKG. I recommend you spend some time on YouTube. There's a couple of great videos explaining EKG, normal patterns, and usually the ones we're after are tachycardia, bradycardia, ST segment elevation, depression, PR intervals, first degree, second degree, type 1, type 2, and third degree AV blocks, that sort of thing. So yeah, got your homework cut out for you for EKG for sure. Is there any course you have for 1 week or so? I'm not sure what you're asking exactly, but like, I have all the recordings you can take on your own, and you could plow through those in a week for sure. But the Udemy course, you can, that's free. You can do that whenever you want. Could we have one more webinar 1 week before? I'll have to see. I'll have to ask my wife. Yeah, part of the reason that is scheduled when it is and why we're here is because busy life. I do have a 9-to-5 job, family, 3 kids, wife that takes good care of me, and yeah, she's very, very nice, very generous to allow me to come down here and have lots of fun in my office with all of you here. I think we had up to 90 some odd of you here tonight, so that was really cool. Let's see. Will I have for course for the July boards? Absolutely. I'll be doing it. I start usually about 8 to 9 weeks before each exam. So for instance, the next exam, so October 29th, I started this class at the first part of September. So we had all of September and October. Now the next one I'm going to start at the end of November, November 29th. There's kind of a little bit of a funny schedule right around Christmas and the holidays. And then the next NPTE is on January 29th. And so that's my pattern. I start the course about 8 or 9 weeks before the next exam. And let me just, again, putting a plug in for my course. The nice part about this course is you get access to a real person. I mean, I obviously don't know everything. There's no way that anyone could know everything, but I've been doing this for a long time now, and I want you to feel like you can access me. Like just today, I talked to someone on the phone from one of my classes. In fact, I do that relatively frequently. I have Skype chats, phone chats, email chats, whatever. I try to stay in good contact with my students. And I think that's the biggest key, is that you feel mentored. Let's see. Nupur, yes, you're so welcome. I really appreciate you all coming here too. I'm going to try to answer, I think there's a couple more. We'll go for probably another 5 minutes or so. But yeah, we're going to dive in. Thank you all so much for being here, by the way. Please do another one next week just to increase our confidence. We'll see. We'll have to see. No promises there, but head over to Facebook and like the page, PT Final Exam. That's going to be your best bet for hearing about this next session. Let's see. What EKG changes are important to terminate PT exercise other than ST segment depression elevation? Premature ventricular contractions, especially in couplets or triplets. This is premature ventricular contractions, or PVCs, another sign of poor muscle or poor blood pumping. Let's see. Oh, here, let's see. Shi Jiao, check Dr. Nijab in your YouTube for EKG lectures. That is a good resource. Let's see, Carly. Carly's been in my course. Join the course, great resource, and my practice scores continue to improve. Thank you so much. I appreciate your shout out, Carly. That's very kind of you. And anyone who's in my class currently, you know, I want to make available everything I've got for you. And that's one of the things that, you know, there's, if you join the full live course, I give you everything I've got. Everything. Maybe too much stuff. I'm planning to take the test in April. So what's the best time to take the course? Good question. Most people that are in the course take it 8 weeks before the exam, so the next one will begin at the end of February, beginning of March. Haven't set the dates yet, but that'd probably be the best time. If you feel like you still need a ton of time, then I would join the next group in November. And again, I'm happy to work with you if you feel like you need to, you know, like I've got a couple people in my class now who are taking it the next time, like in January. And so if they feel like they'd benefit from sitting in on more of my lectures, then you know, no extra charge, I let them sit in on the next lectures. So again, that's the cool part, is you get everything I've got when you sign up for my class. Let's see. All right, I think we're gonna wrap it up. Yeah, we've done really well. I think we've done great. Thank you so much for coming here. This is Sally. Thanks, Will. Hope to see you next week. Yeah, like I said, I'll have to check with my wife about that one. But anyway, I feel like today has been extremely beneficial. I know that, like for me, I obviously had to go and brush up on a few of these things just to make sure I could tell you everything correctly and not give you any false information. But I find these extremely beneficial. And just so you know, I am working on getting a better microphone rather than the gamer headset. That's, I don't know. Maybe it makes me look funny, maybe it doesn't, whatever you want. I guess you get what you pay for when you come here. But yeah, please, just as a final reminder, ptfinalexam.com. Be sure to like us on Facebook so that you can definitely hear about if we do the next webinar either. Again, no promises next week, but we're going to try to do it next week. No promises, but double check us next week, ptfinalexam.com. Check out those discounts I've got. You can go back and look at those Facebook promo for the home study bundle, and then the PTFE for the home study guide. It's about 400 pages worth of material that you'll really benefit from. Okay, so we're going to sign off. And like I said, feel free to head over to ptfinalexam.com. You can comment on the stuff, or I'll be up and on Facebook for a little while too if you want to go to PT Final Exam's Facebook page. That'll be awesome. So, all right, signing off. Good luck, everybody. Good work. If I don't talk to you between now and the test, I'm very interested to hear how the test goes for you. So keep it up.